So our next presenter is Hall of Fame is Dr. Bushnell. And as I said, we're going to move everybody up. So after Dr. Bushnell, be Dr. Vickery, please, and then we'll do the other things just so we can allow our Hall of Famers, many of whom have flights to catch. So without further ado, Dr. Bushnell is Professor of Neurology and Vice Chair of Research at Wake Forest. She's also the Executive Director of the Advocate Health Comprehensive Stroke Program and also Director of the Center for Transformative Stroke Care. Of note, amongst the many noteworthy things that she's done, she won the Kenton Award in 2023. In the same year, she won the SACO Outstanding Stroke Research Mentor Award. She chaired the AHA, pivotal AHA guideline for the primary prevention of stroke last year. And also she's the incoming chair of the American Stroke Council Leadership Committee, which is a very, very pivotal position for stroke under the AHA auspices. She was PI on several different trials which have looked at, studies which have looked at identifying the biological and physiological markers associated with ischemic stroke in women and establishing which of those markers are influenced by sex hormones or menopausal status. She's also been PI on a study that looked at HRT, the effect of HRT on stroke severity in women. Everybody knows Cheryl as the go-to when it comes to being the authority in terms of stroke in women, and she has led the only two AHA guidelines for the prevention of stroke in women, one in 2014 and the other one last year. Without further ado, Dr. Bushnell is going to speak on stroke in women across the lifespan, progress and challenges.
While he's getting the slides up, I just want to echo what the other awardees have said. It's really an honor to be here and to be recognized for this. I have terrible imposter syndrome. I just don't believe that this is, like I'm in the same room with Lewis and Barbara and Bob and Maura. And so anyway, I'll get over it. But I am really, really thrilled to be here, and I'm going to try to talk a little bit about where the state of research is and the clinical care for women with stroke. And I'm going to start, these are my disclosures, but I'm going to start by what SEQUINS means to me. And I'll be honest, I did not know that it was the Society of Equity in Neuroscience at first, because when I think of SEQUINS, I think of my time as a figure skater where I wore sequins. And I even have a horror story about when I tried to sew sequins on my own dress, and I was out competing and all the sequins flew all over the ice and they had to Zamboni the ice before the next competitor could come out. So I was just, it was just morally devastating. But I had a lot of competition anxiety. I did have fun. I loved skating, but I hated competing. But that's what I thought of immediately when I got the email from Bruce about SEQUINS. And so anyway, it's a diversion but the importance of what is being discussed today just can't be emphasized enough. And so I'm going to just talk about the progress that's been made in terms of describing differences in risk factors, unique risk factors, and the incorporation of some of those into the primary prevention guidelines, which has been just a lot of blood, sweat, and tears, but a really something that we should all be proud of. And then I'll list the challenges and where we still need to go. We have a lot of issues with awareness. There are a lot of things that we know as clinicians that are not being communicated well to the primary care community and to patients. We need to develop interventions, and we need to understand the underrepresentation of women in stroke trials. So just to talk about some of the epidemiology, we have an important factor of intersectionality, and I believe it was Mara who discussed this, but we have to understand not only just the person and what sex or gender they are, but also their ability, their class, ethnicity, race, and sexual orientation. And, you know, it's very true that we have a higher stroke incidence in men compared to women, but more women have strokes because of the longevity and the longer length of life to be able to develop a stroke, and therefore more women tend to die from stroke. And it seemed as though the stroke incidence had been decreasing, and this is data through the Greater Cincinnati, Northern Kentucky study that showed that a lot of the progress that's being made was actually a decreasing stroke incidence in men, whereas women were starting to level off, if not maybe increase. So there's definitely still importance in describing some of these differences. And when you look at deaths from cerebrovascular diseases kind of as a whole, this paper is really important. It shows that there are a lot of deaths that are occurring in women versus men, especially at the age groups of even in the 60s and 70s. There are more women who are dying than men from cerebrovascular diseases. And down here is the ranking from 2015 of the leading causes of death. And you can see that there are some age groups where women actually have a higher ranking compared to men, especially here in the 65 to 69 age group. So I think it's important to keep this in mind, that we still have a lot of work to do. And even in younger women, this is a nice meta-analysis by Michelle Leppert showing that in general, the incidence rate ratio of men versus women for under age 45 is still higher in women versus men. And the incidence rate ratio under age 35 is definitely higher in women versus men. It's the 35 to 45-year-old age group where there was really no difference, which is kind of interesting. I think that the under 35 we may be thinking of pregnancy here as a factor in that statistic. But again, to emphasize the fact that men are much more likely to have heart disease compared to stroke, and this is in all of these younger age groups. So definitely still need to pay attention to all the risk factors that overlap in both men and women. But you know, we can always look at the different risk factors and say, well, what can we do as a whole? But I think there are some sex-specific risk factors that we need to pay attention to. Preterm delivery, gestational hypertension, preeclampsia, eclampsia, fetal growth restriction, menarche, menopause, oral contraceptives, menopausal hormone therapy, parity, and gender affirming hormone therapy for trans women. But all the other risk factors, there are some sex differences. Diabetes, hypertension, obesity, atrial fibrillation, and migraine with aura occur in both men and women, but they have a greater risk for women compared to men. Physical activity appears to be about the same. So I want to spend a little bit of time talking about blood pressure, because there have been several cohort studies suggesting that women may have a higher risk of stroke at a lower blood pressure than men. And this particular study, they used a lot of the cohort studies like ARIC, Cardia, MESA, Framingham, and they looked at the trajectory over time. And it's very interesting that in the life course, there appears to be a higher trajectory in women versus men. And this is true for all age groups, which I think is really interesting, especially it looks like after age about 65, women clearly have a higher trajectory than men. And then I think that this has kind of been summarized by Maura, but that women have more non-traditional stroke symptoms and signs. They're more likely to have stroke mimics, and they have longer door to imaging times because of the first two bullets, unfortunately. Moving on to just a description of sort of the lifespan and the unique risk factors for women. Obviously, there are hormonal touch points throughout the reproductive span, menarche, pregnancy, a variety of other things that happen, menopause. And then all of these things can kind of impact the risk of cardiovascular disease, atrial fibrillation, and the ultimate endpoints being stroke and dementia. So a lot of things that happen over the course of a woman's life that impact this. And I'm trying to figure out there, the mouse thing was kind of fine. Okay. So pregnancy. I want to spend just a little bit of time talking about pregnancy and stroke, and you can see what the incidence is here, and this is based on a meta-analysis that Rick Swartz published in 2017. And what it's showing is that basically, you know, this cerebral venous thrombosis is generally 1% of all strokes in terms of prevalence, whereas in pregnancy, it's about a third, close to a third, compared with ischemic and hemorrhagic stroke. So I think that that is an important thing to remember, just the hypercoagulability of pregnancy and the increased likelihood of a cerebral venous thrombosis as a complication. So in our guideline, we really wanted to emphasize what could be done for primary prevention for pregnancy-associated stroke. And one of the major impacts that everyone could have in this situation is to reduce blood pressure that is dangerously high. Because if a woman presents pregnant with a blood pressure of 160/110, the risk of her having fatal maternal cerebral hemorrhage is very, very high. So we had class 1 evidence showing that, and therefore we put in a recommendation that any woman who has blood pressure at this level should get it lowered as soon as possible to basically save her life. And then in women who are pregnant and have a hypertensive disorder of pregnancy, the recommendation is to lower the blood pressure to less than 140/90. And so I think that this is important information. Our guideline was endorsed, maybe endorsed not the right word. It was aligned with the American College of Obstetrics and Gynecology. So they agreed to this recommendation, and it's probably consistent with their guideline as well. But a lot of things happen during pregnancy. It's essentially a stress test. And so you have the intravascular volume, the procoagulants, the inflammation, and then with preeclampsia and eclampsia, you have endothelial dysfunction, blood-brain barrier disruption, and impaired cerebral autoregulation. So all of those things could predispose women to developing a stroke during pregnancy. And if you focus just on the hypertensive disorders of pregnancy, there's been a lot of literature about why these women are at higher risk for stroke later in life. And you can see it has to do with affecting the brain, atrial arrhythmias, hypertension, very high risk of chronic hypertension after having one episode of preeclampsia, heart disease, all-cause death, and then a variety of other outcomes that can occur as well. And then there are a number of mechanisms, but the majority of them relate to endothelial dysfunction as a direct effect of hypertensive disorders of pregnancy. And then adverse pregnancy outcomes also increase the risk of stroke. And other atherosclerotic diseases. But the main thing I'm illustrating here is just how common, if you combine all of these adverse pregnancy outcomes together, it's about 10 to 15% across a woman's pregnancy. So it can be a pretty significant factor and something to be screened for. I'm going to skip over that and just say that Eliza Miller, who is a stroke neurologist now at University of Pittsburgh, has been instrumental in contributing to this literature, and she and her colleagues published Cognitive Impairment Dementia Meta-Analysis Systematic Review, showing that there are real cognitive consequences of adverse pregnancy outcomes. And on the upper arrow here, this is Alzheimer's disease in general. And then the lower section is vascular dementia. So I think it's really important to understand the impact of these. And of course, there are a lot of things that can happen between having a pregnancy outcome and being, say, 65, 70 years old. And I think that that's where our preventive approaches could be focused to try to prevent this type of adverse outcome. So in our guideline, we recommend screening for all of these adverse pregnancy outcomes, including miscarriages. And if somebody does screen positive, that's an opportunity for evaluation and management of vascular risk factors. And we consider this to be a Class 1 recommendation. And fast forwarding to menopause, we have a number of factors that cardiovascular changes at menopause. We have plaque initiation that can occur from a variety of risk factors. And then as that plaque accelerates, then there's an increased risk of progression and thromboembolism. But the age that all of that occurs can be a very important factor. So multiple studies have shown that if you have menopause that occurs before the age of 45, that there's an increased risk of stroke. And if it's before the age of 40, it's even a little bit higher. So in this European study, the mean age of menopause was 46, but they calculated that there was a 2% lower total risk for each year menopause was delayed. So the later you have menopause, the more protection theoretically you have with estrogen on presumably healthy blood vessels. I should say that's a physiologic amount of estrogen. So then there's been multiple studies showing that early menopause does increase the risk. This is just another example of several studies showing the same thing. It's about a 40% risk if you're under 40 and about a 30% risk if you're between 40 and 44. So another way to think about the early menopause is reproductive lifespan. So that's the time between menarche and menopause. And the shorter your reproductive lifespan, the higher your risk of stroke. And so the thought is that it's probably related to early menopause, but overall, if you look at reproductive lifespan being shorter, that's less benefit from physiologic levels of estrogen. There are a lot of different challenges with studying this, including how to calculate estrogen exposure related to pregnancy, breastfeeding, a variety of other factors. But this is currently something that's being, I think, needs more research in terms of systematic measurement of estrogen. But in our guideline, we do recommend screening for early menopause, either premature or ovarian failure before the age of 40 or early menopause before 45. And then to really take that opportunity to intervene if necessary, if there are risk factors that need to be modified. And then hormone therapy use, we know, is associated with a variety of negative impacts. We know that there's an association now with subarachnoid hemorrhage, and that there's a really important group of women who will benefit from hormone replacement therapy, but there are a lot of caveats to that. So only severe, moderate to severe vasomotor symptoms, and making sure there are no contraindications based on cancer or cardiovascular disease. And then ideally less than age 60 within 10 years of menopause onset, no cardiovascular risk, and then to really focus on either the low dose oral formulations or even a transdermal formulation. So this is kind of the algorithm that we included in our guideline. Endometriosis is another risk factor that's kind of recently been elucidated, and it was really nicely illustrated in the Women Nurses Health Study, showing that if they did have laparoscopic proven endometriosis, that there was about a 34% increased risk of stroke, but about 39% of the modified or the mediation of that risk is from the hysterectomy oophorectomy, which is the treatment for endometriosis. So I think it's really important to account for all the different things that happen as a result of the diagnosis. But we did put this in our guideline because it certainly is a reasonable thing to screen for, and that if you do screen positive, that it's important to understand their vascular risk factors and the modification of those. So outcomes clearly are different based on sex. In crude analyses, and Mara presented some of this, that women appear to have a higher mortality, and it's attributable to age, gender, stroke severity, and pre-stroke status. And a lot of this, I think, is related to the fact that women are more likely to have atrial fibrillation. Fibrillation is more likely to cause severe strokes. And then I'll talk about the work by Matt Reeves and his colleagues here, showing that in pooled analyses, you have crude mortality rate ratios of about 35% higher in women versus men. But when you account for all the other things that we know are important, like age, pre-stroke function, stroke severity, AFib, everything reverses. So you have mortality rate ratios that are actually beneficial in women compared to men. Still important to describe the crude comparisons, however. And in AHA scientific statement, they showed that endovascular therapy can be different in women versus men, that there are sex differences, that women have smaller, potentially more fragile arteries, but they also benefit more from EVT than men. And there are some issues culturally. Some of the families may be less willing to pay for endovascular therapy, which is actually required in certain countries. You have to pay for it before you actually get treated. And then obviously women or anyone has to understand that they're actually having a stroke and to seek treatment quickly. And then I think it's really important to understand some of the functional differences. And this was a Canadian Community Health Survey combined with a European Health Survey, but they also included the Gender Inequality Index, which is an index that's country specific, and it encompasses reproductive health empowerment and the labor market. And just to show you here that this is instrumental ADLs, that women have a much higher risk of poor and needing assistance with instrumental ADLs than men. And the same thing was shown with activities of daily living. So just to kind of wrap up and talk about some of the challenges, these are just a summary of stroke in women across the continuum. The differences in risk factors we've kind of gone over already. Less complete evaluations. The stroke mimic issue is a big one. Treatment, less likely to be given thrombolysis IV, but more likely to be treated with thrombectomy, and an underrepresentation in clinical trials. And then, of course, the outcomes we talked about: higher disability and higher crude mortality. And then, of course, older women suffer from social isolation, which can contribute to all of the things that we've talked about in terms of getting treated and getting the right care at the right time. And then I wanted to mention this study, which I thought was really excellent. It's a look at stroke symptom awareness among U.S. young adults. And this is from the National Health Interview Survey. And they assessed whether people knew what the 5 common stroke risk factors were, stroke symptoms, and knowledge of planned response. And this is almost 10,000 people under the age of 45. And the good news is that by sex, there's really very little difference, but still it's 2.9% of women and 2.5% of men could not name the 5 stroke symptoms, which is concerning. And a similar proportion were unaware of what to do with if a stroke was recognized. I'm going to skip that and then talk about clinical trials. And one of the proudest things that I've experienced in my career was to kind of leave a legacy. So in 2005, I was personally being kind of like intellectually and personally trying to figure out what do we do after the Women's Health Initiative showed that these outcomes, hormone replacement therapy, and a lot of other outcomes were associated, or that exposure was associated with increased stroke risk in women. So what do we do to try to keep the field moving forward? It was really hard to get funding for sex differences research after the Women's Health Initiative. And Matt Reeves can tell you how hard it is. He tried multiple times. And so I put together a conference grant with NIH, and it was the advancing the study of stroke in women. And Virginia and Matt decided that they were going to do kind of the second version of this last year, and it was incredibly successful. Some of you in the room were there, but there was a lot of emphasis on clinical trials and how to get women and other underrepresented folks into clinical trials. That was kind of the majority of the discussion. And I show you this figure because it really does emphasize a lot of the things that can be done to think about study designs, how we talk to people about clinical trials. And I know this is small print, but if you go to the scientific statement that was published by Joanna Ospel in 2022, looking at the disability, the presentation, the mobility of women, the caregiving responsibilities, the influence of family members on decision-making, the risk-averse attitude among many women, investigator biases, older age. A lot of trials use age 80 as the exclusion criteria. Above age 80, you cannot be in a trial. And this excludes a lot of women with stroke, unfortunately. So just trying to understand exactly what features of trial design could be more inclusive, I think is what this is getting at. And I think it's a great figure. But I think in addition to representing women in trials, more women who are recruiting for trials can also improve that metric. And I think we have an underrepresentation of women as PIs for trials. Not that this is an easy thing to accomplish, but I think it's really important that we recognize that there is an underrepresentation here, and an underrepresentation of women as first authors. And this particular study from the vascular surgery world, they looked at clinical trials from the highest ranked journals, New England Journal, Lancet, and JAMA. And they looked at female authorship of these clinical trial publications. And if both the first and the senior authors were female, this correlated with higher female enrollment in the trials compared to male authorship. So I think it's just an example of the leadership opportunities that women have to enroll women in clinical trials, and that could maybe start to move the needle. So I'm going to summarize that we've made great progress in understanding some of the sex-specific and unique risk factors. We've incorporated these into guidelines, and we understand a little bit more about why women have worse outcomes, but we still have the issue of underrepresentation in trials, more leadership as PIs and authors, and then awareness of stroke symptoms and screening and what to do, tied to social determinants of health for sure. And we need to increase awareness of the risks of adverse pregnancy outcomes and early onset menopause, and to develop some interventions for that. So I'll stop there, and I thank you again for the invitation and the honor.
Fantastic. Thanks so much. Questions? So I'll start off with one. So Cheryl, you're one of the few people I know who has actually been the first author on 2 guidelines 10 years apart. So I think the question I have for you is, after the 2014 guideline, what was your impression of the uptake in terms of those recommendations and in terms of gaps that were actually addressed before you now wrote the 2024 one?
I think in 2014, we still lacked a lot of really convincing data. And then the other thing that changed over that time was obviously lots of studies being published, but also the guideline writing process had changed for the better, but still, a lot of work, as you know. It's just why was I involved with both of them? Because because they wouldn't let me say no. No, but it was important to do again. And I think the main thing is just the amount of data that was available. And the uptake, I think, was modest for the first one. Yeah.
Dr. Adams?
May or may not prove, it may not make any sense. But what if I said that you and the persons like you leading these things, you have potential allies in the business world in terms of women running corporations that you did not have 20 years ago, and that they can help you really perhaps move it.
Oh, I love that. I would say that's really important. And there's also an increase in women leadership at dean's roles and CMOs in the academic world as well. And so I absolutely agree with that. The networking that happens with the executive leadership in academic medicine, or ELAM, is also a great support for exactly what you're talking about. But yes, I think having these networks across, outside of academia is really important. Thank you. Yeah. Yeah. No, I completely agree. There's been some great books written for leadership in general, and I think all of that applies to leading teams and research.
Other questions? If there are any others, please feel free to contact Dr. Bushnell. Thank you so much.
Thank you.